Hello, good evening, good afternoon. Happy that you join us on our Wednesday webinar together with Marianna Arvanitakis.
Hello, everybody.
Yeah, this is a special webinar, Best of ESGE Days 2023. 3 weeks ago, we had a wonderful meeting in Dublin. Many of you probably participated, and I'm sure you couldn't see everything. So the idea is to have, on the one hand, still the Congress is available on demand, but we selected for a special of webinars now highlights, the best abstracts. It was a huge number of wonderful abstracts, but this is still also a small percentage we can present you today. And we start with upper and lower GI abstracts today, which will be presented by Miguel Areia and by Maria Pellisé. And thank you both to you who selected out of several hundred abstracts. Very interesting. This is your selection, and we have also the opportunity that some of the authors of these abstracts are here today, are joining us. And you can ask some questions directly by Q&A. Otherwise, I think although we have questions to the authors, but for now, I think we can start, Marianna.
And also, Helmut, the next part of this webinar actually is going to be the 7th of June for HBP, for hepatobiliary and core in US. So we still have another webinar to explore all the fantastic abstracts that we received.
Yeah, and at the very end, we have them planned for the 28th, for the live transmissions from Hamburg and from Dublin. So the next couple of weeks, you can always enjoy ESGE Days. And I've heard we have today several hundreds participants again. So thank you for joining. And now, Miguel, it's my honor to introduce you. You're an expert in upper GI, and you are in the scientific committee responsible together with Marianna for the program. And now you selected a couple of interesting abstracts, and we are now very keen and very excited. What is your selection, Miguel, please?
Thank you, Helmut. Thank you, Marianna. Hello, everybody, dear colleagues. It's a pleasure to have you here, and it's a pleasure for me to be presenting this talk. And of course, I have to say that two things. It's a pleasure to be here. Second thing, I don't have any conflict of interest for this presentation. And the third thing is, of course, this is a personal selection of 5 of the wonderful abstracts that we had in Dublin. And I tried to choose 5 topics related to upper GI. One related to follow-up after resection of adenocarcinoma in Barrett's. One regarding the rates of post-endoscopy upper gastrointestinal cancer in upper GI. One regarding a quality improvement initiative specifically for Barrett's esophagus. One for the endoscopic vacuum therapy. And finally, one model for risk assessment for rebleeding in non-variceal acute upper gastrointestinal bleeding, non-peptic, non-variceal bleeding. So, first of all, endoscopic follow-up of radically resected submucosal adenocarcinoma in Barrett's esophagus. So this is an interim result of a still ongoing prospective international multi-center cohort registry called the PREFERRED trial. And background on this is related to the fact that if you have a visible lesion in Barrett's and you resect it by endoscopically by EMR or EST, currently the rates that we know from surgical series from invading submucosal cancer, so T1B adenocarcinomas, the rate of lymph node metastasis goes as high as 46%, and that's why it's still regarded as a surgical option to follow these patients, because we cannot achieve curative endoscopic resection. But after some recent studies, this rate might be as low as 16% and not 46%. And that's why that eventually an endoscopic watchful waiting, that's why the PREFERRED trial, can be a chance for these patients. And this is what was tested in this multi-center international registry. So this goes with 20 international centers in Europe. The sample size, they pretend to include 141 patients, and it's a long follow-up of 5 years. And of course, the main outcome, it's the 5-year disease survival specific, it's also the overall survival. And of course, they will also look for lymph node metastasis, local recurrence, eligible for re-endoscopic resection, local recurrence, but not eligible for endoscopic resection, distant metastasis, and quality of life. So what they did, so if a patient has an endoscopic resection, and it's considered a T1B, esophageal cancer, is again restaged with upper GI, EUS, and CT, and if it's confirmed N0, M0, and after consent is included in the study. And at start, they divided two risks, the high risk group and the low risk group. And for the high risk group, it has to have at least one of these variables. So submucosal infiltration above 500 micra, a poor or undifferentiated cancer, or presence of lymphovascular invasion. If all of these are negative, it will be considered a low risk group. And then for the 5 years, you will have a strict, quite demanding endoscopic follow-up with upper GI and EUS, and also with a CT scan after 1 year, and they are intended to follow the patients for 5 years. So the first results in terms of inclusion, they are almost, so they want 141, they have already 134, most of them higher risk, more double times the low risk groups. And by now they have 17 follow-up in one side and 14 in the other one. So they are still finishing inclusion, but the follow-up for 5 years will stay for a long time. And the main results, in my opinion, are that the lymph node metastasis in the high risk group is just 5%, and the tumor recurrence is only 6%. And for the low risk group, it's only 4% for the lymph node metastasis and only 4% for tumor recurrence. So in my opinion, the main results that we can see from here is that the rate of lymph node metastasis was just 9%, and all of these patients were submitted to a curative surgery, and they got cured of the cancer, although instead of going directly to surgery, they went to this follow-up trial first. And the rate of tumor recurrence was just 10%, and of these 10%, 5 patients were in the high-risk group, and we have a mixture of results. We have patients that were cured with surgery, patients that were straight to palliative care, patients that were cured with chemoradiation, so a mixture of cases in these 5 patients. And again, the 2 low-risk patients had again a curative surgical resection. So I think the main conclusions that you can see is, in fact, this study is showing that, in fact, we have a lower rate of metastasis, especially for the lymph nodes, and that this strict endoscopic follow-up for T1B cancers, adenocarcinoma in Barrett's esophagus, seems feasible, although the trial is not finished, of course. And even for those few cases, like 10 or 19% in this case, that will progress, local or for the lymph nodes, most of them, the curative treatment by surgery or by endoscopy is still possible. So I think that the main question that might come up, so again, the study is still not finished, is if this correct stratification or selection of patients will help us in the future to choose who will go for surveillance and who will go for surgical treatment at start. My selection number 2 is this study, so variation in post-endoscopy gastrointestinal cancer among endoscopy providers in England and associated factors. So this is a population-based study from England, from Dr. Kumran. And we know that the rate of post-endoscopy upper gastrointestinal cancer, which is a cancer diagnosis by definition between 6 and 36 months after an upper GI, so something that was there that was not detected, and it's proposed as an important key performance indicator for quality in endoscopy, like we use also the rate of missed cancers in colonoscopy. Although it's difficult to measure, and that's why the relevance of this kind of studies. And they picked up 2 databases. So from the last 10 years, all individuals diagnosed with esophageal or gastric cancers in England were picked up, and they linked to a second database with hospital records for all patients that underwent an endoscopy within 3 years prior to the diagnosis database. And so those that had an endoscopy in the previous 6 months to the diagnosis was considered true positive, and all of the other ones that had one endoscopy with no diagnosis of cancer would be the false negatives to calculate the rate of missed cancers. So they had more than 100,000 endoscopies and almost 100,000 cancer patients. And the rate of a missed cancer in upper GI in the last 3 years is 8.5%, with a very narrow 95% confidence interval between 8.3 and 8.7, so a quite high. And in these two charts, if you see on the left, if you see in the last years, and this is the same for the 10 years of the study, the rate is quite stable, around between 7 and 9%. So the rate is not going down, and eventually it might even be increasing in the last years. And this is the rate by provider. So all the providers that have one endoscopy, and most of the providers are around this 8%, although we have some outliers where the rate might be as high as 15% of missed rates. And in the lower, it's even around 5%, so it's not close to zero. So we are in fact missing cancers. What were the most common lesions that were detected in the previous 3 years and might eventually be a cancer that was missed? Mostly esophageal lesions like ulcers, Barrett esophagus or strictures, but also gastric ulcers that might be a cancer and was diagnosed as a benign gastric ulcers. And another relevant issue was that they looked if the center was accredited by the ESGE advisory group, and using the accredited centers as a reference, those that were not assessed or not accredited, this was a risk factor for increasing the risk of missing cancers with a 1.24 value. So the main results is that the post-endoscopy upper gastrointestinal cancer missing rate is 8.5%. And there's although the rate is quite stable, we have a threefold variation among providers, with some providers going as high as 15%. And the lowest goes to 5%, but we don't have people that are near zero, which would be the ideal world. So the main conclusion, in my opinion, is that upper GI missed cancer is still high, and unfortunately, it's still stable if we use these results. And the most lesions that are being neglected are esophageal lesions, Barrett ulcers and strictures, and gastric ulcers that are being neglected in the previous 3 years. In the future, what we need is to prove that if quality improvement by self-assessment, for instance, the ESGE quality app or accreditation like they have in England, if we can prove that this will in fact improve the outcomes of our patients, because 8.5% of missed cancers is too high. Abstract number 3. So this is called the sustained standards for Barrett's esophagus by implementing key performance measures. So this is a quality improvement initiative from Australia. This is a single center. And the background for this study was that we know, and the authors state that improving quality in Barrett's is expected to improve the outcomes. And because the European Society has published key performance measures just specifically for upper GI, but also specifically for Barrett's, they want to assess the impact of implementing these performance measures in improving quality in Barrett assessment, not just once in time, but if this could be sustained in a long term with regular educational measures. So what they did a baseline retrospective study in 2019, and then every 6 months, and not just once, they have educational interventions, both for endoscopists and for nurses, according to the European guidelines. They had meetings in the hospital with videos. They put pictorial descriptions in the endoscopy suites in the walls for people to just look around to recall. And then they had nurse education, and this was repeated at 6 months, 1 year, and 3 years from baseline. So they measured pre-procedure metrics like appropriate indication, consent, or safety checklist, and also key performance measures during the procedure and after the procedure, like use of part classification, Seattle protocol, use of targeted biopsies, inspection time at least 1 centimeter per 1 minute per circumferential centimeter, use of advanced imaging, and if the surveillance recommendations were according to the Australian guidelines in this specific study. What you see here, the main results. So going from left to right, you have the baseline in blue, then 6 months in orange, 1 year in green, and 3 years in yellow. And what you see, if you only look for the blue lines, at start, they were quite low and quite below the threshold that we in the European Society recommend. The first good news is after the first assessment, they go sky high, and there's an amazing improvement, almost perfect. So the orange lines go almost always to 100% or nearby. But then in 1 year and 3 years, what you see is that they tend to decrease, although most of them still stay on the threshold above 90%. Some of them stay perfect, which is the ideal world, but also some of them lose again the ideal threshold. And even after a second and a third evaluation, it's difficult to put people reaching, for instance, in this case, the use of the Tract classification. So quality performance measures above 19% were achieved, except for the Tract classification, at least on the long time. And an impressive initial improvement might not be sustained on the long time and after the first improvement. So in my opinion, the main conclusion is that measuring quality always brings points to improve. When we make a first measure, we always find things that are not so well as we thought, but also that a sustained evaluation is a key for a sustained performance, because after a first well improvement, things tend to go low in time, and we need to keep high in our quality. In future, we still need to convince people that quality measurement will correlate with retroclinical performance. And this is another more study saying the same. So let's see if the message goes to convince people. The fourth abstract is this endoscopic vacuum therapy for the treatment of upper gastrointestinal defects. And this is a result of a Spanish multicenter registry. So in the last years, we have a lot of papers on this new endoscopic vacuum therapy that has emerged as a useful tool for patients with upper GI defects. And they have a high efficacy, between 80 and 90%, and a low rate of adverse events, but most of them are retrospective, with a low number of patients, and only one study evaluated the risk factors for failure of this treatment. And what they did in Spain, they registered all these procedures from 19 hospitals in Spain in a prospective record, and this goes for the last 5 years, and people are followed up for at least 6 months. Main results from the study, they have already 102 patients included, and things that caught my attention. So at least 1/3 of the patients had the neoadjuvant therapy. So these are difficult cases, but these are also difficult patients. When we talk about the defects, most of the defects are anastomotic leakages, but not all of them. So we have also some perforations that might not be the same thing as the leakages in terms of response. Of course, that most patients had a surgical, an oncological surgery, but it's also relevant to the cases of obesity surgery that come up with this kind of complications. And another relevant fact was that around 20% of patients had at least a second surgery before any attempt of an endoscopic treatment. And this is a message that we need to talk with our surgeons and for them to be aware that we are available with several things to do before they go again to the operating room. So another interesting issue for me was that delay of the initiation is almost 2 weeks. And we see patients that go for the first sponge after 1 week, but we have also people that go after 4 weeks, which is too long for sure. Regarding the procedure, we have intercavitary and intraluminal sponges, and perhaps in the same patients both. So I think we still have to standardize what we are doing. Of course, the number of sponges will depend on the size of the cavity. But then again, it's relevant that also the duration will come up with depending on the size of the cavity. But the main result is that the results in Spain are similar to what was presented in previous studies, so above 80%. But the rate is different. So for perforations, it's higher, above 90%, but for leakages, it's around 80%. And it needs to be stressed out that these are really difficult patients and difficult cases because the mortality is 1 in every 5, the global mortality around 20%, with an in-hospital mortality of 12.7%, and also with some complications of the procedure. So these were the facts that were related to the failure of the treatment. Although in multivariate analysis, only the delay of the initiation of the treatment correlated with the failure of the treatment. And for mortality, the two most relevant things after multivariate analysis was a post-EVT pneumonia, might be related or not, complication of the technique by itself, but the failure of the vacuum therapy was related to mortality. So we need to improve the initiation to improve the failure rate. So in conclusion, the main results were a good efficacy, although it's different from perforations and for leakages. Beyond efficacy, mortality is still relevant. So we are talking about 1 in every 5 patients that will die in global, even with our help. The main conclusions, in my opinion, is that, of course, this is a new option for a very difficult situation, but I think that the main message that comes out is that the sooner, the better. So we need to put this message to our surgeons that we have several things, and now also the vacuum therapy. So I think we still have a lot to standardize, the indications, the methods, the replacements, and the time. But I think this will come in with more studies in the near future. And I think we still need to improve efficacy and avoid or reduce the complications, because complications exist and they will be correlated to the endoscopic vacuum therapy failure. And we know also from this study that failure will correlate to mortality. And finally, this study from Italy with risk factors for rebleeding for non-variceal acute upper gastrointestinal bleeding, not only stigma matters, but this is a prospective cohort study. So we know that bleeding and rebleeding is significant in terms of mortality and death risk. We know that there are a lot of scores, but they are not perfect, and some of them are not so quite easy to use. And the aim of this study was to try to create a new model, a rebleeding model, compare it with the forest classification and other existing scores to see if we could get a better model and more easier to apply. So this is a prospective multi-center study in 50 Italian hospitals, and they considered a lot of predictive factors, clinical factors, endoscopic factors, and treatment factors. And the main results, so more than 2,000 patients from 50 hospitals. The mean time for endoscopy was 5 hours, but with a very large interquartile range from 2 to 12. The peptic ulcer in this group was just a few more than half of the patients. So when we are talking about non-variceal bleeding, it's not just ulcers. And a very high rate of high-risk stigmata. Again, almost half of the patients had a high-risk stigmata. And the real bleeding rate in this cohort was 5.6%, so a still relevant issue in 2023. And we are not being able to diminish this rate of rebleeding patients. But in my opinion, this is the most striking number, is the very high variability in between hospitals in the way to start the first endoscopy. And these were the facts they correlated with the risk factor for rebleeding. Some of them that are clinical, and it's not for us to change this. It's just to be aware that, for instance, a cancer, it's a risk factor, or the presence of hematemesis is a risk factor for rebleeding. Also that ulcers and non-ulcers is not, of course, it's a risk factor, but it's not the same. But for me, the main relevant issue is this number, that we know for sure and for a long time that injection only is not right, and that's why it is a risk factor, and it's one of the highest with an odds ratio of 2.67. But if this is a risk factor, it's because many people are still using only injection as a therapy method. This model in particular, and it's not clear for me from the presentation how the model is built and how it is scored, but the model, which is this line on the top, it scored better than any other model that we have already, also for all causes, but specifically also for just peptic ulcer. So the model seems to be better than others existing, but we still need to validate and to know how to apply and to see if it helps for every case. So main results, rebleeding rate of 5.6%. The area under the curve was between 0.76 and 77, which is above other available and already validated scales. The main conclusions, in my opinion, and still have a room to improvement in daily practice, and time to endoscopy and using injection only. I think that we need to improve in our daily practice because we are still not doing the best to our patients, and this is a risk factor for bleeding and the risk factor for death. And we need to validate and simplify this score to see how it goes versus the other ones. So in future, I don't know if this is, or we are still waiting for one perfect and simple score for all upper GI non-racial bleedings. So this is my final slide. Don't forget that ESGE days are still on and on demand until the 30th of June. And thanks for your attention.
Yeah, thank you, Miguel, for this wonderful selection. Now,
thank you, Helmut.
Marianna is here, and now we have two out of the 5 authors are also online. I think it's Roos Pauw from the Netherlands, and Umay Kamran, is he also here?
Seems to be also. Yeah.
Yes. So at least two presenters, 2 experts, whom we can ask directly. So for those who attended a bit later, Miguel selected 5 abstracts, and from these abstracts 2 authors are today here, so we can ask them directly. Otherwise, please use the Q&A for questions, and then we hope we can answer or we can discuss what is our experience. So let's start with a question from the, well, perhaps we go through the abstracts and start with number 1, Miguel, huh?
Yeah, so the first abstract, yeah,
that would be the paper from Roos.
Yeah, I think she's already responded 1 or 2 questions on the chat. So Roos, this is a surveillance strategy for patients after resection of an adenocarcinoma in Barrett's. And so the background is that eventually the lymph node metastasis is not as high as told in the last 3 years. And so you are proposing a surveillance protocol. So in my opinion, the results are quite good. I think my main question at start, if we don't see more questions, is, but it's a quite demanding follow-up. So because we have endoscopies every 3 to 6 months and EUS and CT. So is it feasible? Do you think it's feasible for patients to do all this procedure? This would be my first question.
Yeah. So first of all, thank you for selecting our abstract, of course. It's always an honor to have it highlighted. So to answer your question, so I think what's also important to stress is that the rate of lymph node metastasis in our study is lower than what we know from literature, but also I think that's mainly because we do a very strict selection of patients that can enter. So they can only enter the study if they don't have lymph node metastasis at baseline. So we're looking into those patients as well, and we will report that at the end of the study. But there are some patients that have lymph node metastasis at baseline that are that do have surgery or chemoradiotherapy, but those who don't have that at the beginning enter the follow-up program. And it is indeed quite strict. Most patients actually find it okay. So we're doing quality of life questionnaires in these patients as well, because we always think that that it's a burden for the patient, but we also know that patients are often very reassured if they are checked and everything is okay. So the questionnaire will have to learn, if that's true and what the patient would prefer. And also, once we have the results, we will be looking into when the lymph node metastasis that occurred were found. And maybe when we have all the data, we can make it a little less intense, for example, do it every 6 months, or lose the CT scan because that didn't show much so far. So,
Roos, so you are still on the follow-up and you are still missing data for the 5 years, but from your experience by now, most of these recurrences to the lymph nodes or local recurrences, they come up in the first year. You have people that are completely normal for 1, 2, 3 years, and then they come up. Do you have any idea or from your experience right now?
Yeah, so most of them are detected during the first year. We had one case that was detected with a lymph node metastasis, a very proximal one, that was detected after 18 months. But most of them are detected somewhere in the first year.
Bruce, it seems to me the bird is always similar, the same situation as in the colon. In the colon, we also had the border for submucosal infiltration for low risk was 1,000 micrometer. Meanwhile, we have data from Japan that submucosal infiltration obviously is not as important as tumor budding. Maybe the limit can be 2,000 micrometer or much higher. Or yeah, and do you think we should have, after this data are available, increase also the invasion depths, or is there also from the pathologist other risk factors like tumor budding? And my second question would be, we know the data for high risk and low risk were surgical patients. So do we have a selected population in our group where we exclude all those patients who had an endoscopic ultrasound with enlarged lymph nodes or with G3? These were all patients who were involved in the surgical group. So are we talking about two different populations you examine in your group?
Mm-hmm. Yeah, so to answer the first question, so we will be doing pathology revision of all the patients that were included, to have 3 pathologists look at all the histological risk factors. But so far, the interesting thing is that in the low risk group and the high risk group, the rate of lymph node metastasis is actually the same. Of course, in the end, it would be very nice if we could make sort of a prediction model to predict the patient's risk of lymph node metastasis. But the problem is that the rate of events so far is too low to actually do that. So we are planning also to extend the study once the 141 patients are reached. But that would be ideal, that we could have a good definition of who is at high risk and who has a lower risk. And regarding selection, I think so of course, there are some patients that are still operated on or that prefer surgery. And we do have sort of a screening cohort where we also look at the outcomes of those patients. But I have to say that, for example, in the Netherlands, where the most recruiting sites are, all the patients, I think the vast majority is included in the study. So there's not too much selection bias there.
Great, thank you. Maybe we should go to the second abstract, Miguel.
Yeah. So,
Dr.
Cameron, I think nice
Hello.
to see you again. So, Dr. Cameron, so one question. So, you use data from databases, but I think you didn't have access to the endoscopic report by itself. So I think just to be sure, so you can link diagnosis with cancers, but it's not possible, at least at this stage, to see if taking pictures, taking time, using Symmetricon, or this kind of things that we talk about in quality, they are not available to check. Is it right?
That's right. Thank you very much for the invitation. So for this particular study, we did not have access to the individual endoscopy reports for all of these patients. However, in the next phase of this study, I am using a database which is we call National Endoscopy Database in the UK, which some of the people might be aware of. So in that database, we do have access to all reports, and we are analyzing the different endoscopy practices and how the endoscopy is done differently between the providers. So for that purpose, we have selected providers with the highest project rate and the lowest project rates. So hopefully that will help us in further examination of the, in more granularity to look at the differences. But for this particular abstract and this study, which we have presented, we did not have access to endoscopy reports.
Yeah, I think that data will be very relevant and help us a lot in the next years. Also, do you want to add any comment comparing the fact that you have accredited centers and not accredited centers, and you find it as a relevant result? Do you want to make any comments on this?
Yes, sure. So in the UK, again, Joint Advisory Group on GI Endoscopy, they offer this accreditation scheme, which is voluntary scheme in which the providers can participate, and then their services are analyzed against some certain standards. As you briefly mentioned, that these are self-assessment and assessed by the external assessors. So this was very interesting because these accreditation schemes do have quite holistic assessment of looking at the patient experiences, waiting lists, training provided by those providers, by all the centers. So it seems like all like holistic approach does seem to have impact on the quality of endoscopy, which is very interesting. And I think that in the future, more studies would look at it prospectively, and it will be very important to actually find out what particular area in the accreditation does have direct impact on the quality of endoscopy. But seems like external assessment and accreditation do improve the quality of endoscopy to some extent, and will help us in future, hopefully, by to avoid missing the cancers. So this has been taken very positively in the UK, especially, of course, by the JACS scheme as well. So we are hoping that more, because currently I think there are about 500 providers are participating in this accreditation process, but there are still fewer the providers which haven't contributed towards this process. So hopefully there will be more contribution.
Yeah, hopefully with your results, they will also try to be accredited and get better.
If I can just add something, if we paralyze again with the colon, as Helmut did, I think that despite the fact we're getting better in our quality measures in the colon, it seems still challenging for the upper GI. And we can see it also in how we train our fellows, etc., that it's still difficult to correctly examine a stomach and to detect.
And I think one thing that we need to do also in the European Society is try to see what are the most relevant things, because we can talk quality about 5 or 50 or 500 things that are relevant, but those 5 or 10 things that are really more important and that will make the difference. So people will focus on that before trying to move to be even better or perfect. From what I see, I think we have the author from the third study.
Yeah,
Dr. Subaharan. Yeah. From Australia, not sure. Eventually, if he, I don't see any question.
You see the name, but maybe.
See his name, but I don't see. He's muted, and I don't see him.
You cannot hear or see us. Dr. Subsaharan, can you hear us? If yes, then would be nice. We can discuss your paper. Otherwise, if not, then I have a question. Then maybe Ruth, you can answer the question. Is it a buried abstract? And what is your expertise, or how is in your center? How are you training your colleagues to improve the detection and the inspection of the buried cancer? And do you also see there is in the initial phase, as Miguel showed in the abstract, you have a dramatic increase and then it goes down? It looks like to me that you show awareness, but then you're lost again. What is your experience in your center?
Yeah, so we don't really register the very strict all the quality parameters, but what we usually do is that we have like 5 simple sort of rules. We always when we do the endoscopies together and train the fellows for upper GI endoscopy or the Barrett's inspection, to really like stress the fact that they should clean the esophagus really well, so you can inspect the whole mucosa very well, that you take your time, so inspect at least 1 minute per centimeter of Barrett's, do a very standardized pullback in white light, the same with virtual chroma endoscopy, inspect and retroflex position, and really play a little bit the insufflation and desufflation, and we try to sort of do a structured way of doing the gastroscopy. And what we also ask our fellows to do is to train in recognizing early neoplasia, because if you do a very good endoscopy, it's also good to be aware what you should be looking for, how early neoplasia looks. So they do training modules to familiarize themselves with the appearance. But we don't have a really good, we don't look at learning curves or etc. So it's sort of a very structured way of doing the endoscopies together and then having them do it alone. But we don't record other quality parameters.
Maybe we can continue because of time to the number 4 of the abstract with the sponge therapy, the registry from Spain, which is a huge data set.
Here we had a comment of an answer and a question from the audience.
Oh yeah, okay.
About about the indication of SEMS. Is endosponge going to take over the SEMS, or the endoscopic vacuum therapy is going to take over the SEMS, or is there still indication for putting SEMS?
Yeah, good question.
For upper GI defects.
We have not the authors here, but we have an expert for GI here, Miguel.
Yeah, so I don't want to take much time for the next presentation for Maria, but I think that we have options. We have the clips, we have the stents, and we have the sponges. I think in the next years we will have a better picture of what to put in what situation. So not using 10 years ago we were putting clips for everybody, then we were putting stents for everybody. Now we are putting sponges eventually for almost everybody. So I think in the next year we'll have a better picture. What is best in which situation?
Yeah, our experience in my unit is if you have an immediate perforation during a procedure, you should either clip or put a stent, because then you have no risk for a huge infection. If the perforation takes longer, if a leakage after surgery, which is diagnosed a couple of days after the surgery, then the sponge therapy seems to be the method of choice. And you showed in the abstract that the time delay is obviously a risk factor, whether it's a successful and how is the outcome. Like, although in our experience, if you use this sponge, you should start very early. And I know there is one group in Germany that put in a sponge after each resection in the esophagus to protect the anastomosis. This may be over-treatment, but shows that time plays obviously a role. Huh?
Yeah, very much. I have the same feeling.
Okay. Last abstract.
So we have two quick questions about the last abstract. Is also I had also, it was something that I found it striking, that the time to endoscopy was medium, was 5 hours and 2 to 12 hours, which is shorter than the ESG recommendations. So that was I found that kind of surprising.
Yeah, but even though it's quite with a huge range from 2 to 12, so I'm not sure if that doesn't play some role in the final results. But for me, the most striking thing was the injection only, as a relevant therapy still for many people from these results, which are from the last year. So this is not a study from 10 or 15 years ago. So I think that's the main thing that we need to change.
And I see here we have the author, I think that she's online. The study was conducted between 2015 and 2016. Guidelines were different about the timing. So that explains it well. Okay. So maybe we can continue with Maria.
Okay, then thank you, Miguel. Thank you to the authors, Ruth, Dr. Cameron, and then we continue with lower GI.
You're welcome. Thank you.
Oh, hello. I am Maria Pellisé. I'm going to share my screen. So I'm going to shortly present the best of the ESGE days for lower GI tract. Here are my conflicts of interest, and personally, mostly here I have a conflict of interest that I have chosen totally by a subjective and personal choice. I have based it on the the ones that were best rated, but of course there were so many good abstracts amongst the very good, the best rated and the rest that I just choose 5 of them. So mostly there was a session that was devoted to post-colonoscopy colorectal cancer. That was a very interesting session, and there were several nice abstracts there. So I chose 2 from that session, and I thought that it was nice first to introduce a little bit what was post-colonoscopy colorectal cancer, because there's still some confusion sometimes with the terms. And this was very much well explained by Matt Rutter in an article, and has been very much developed inside the World Endoscopy Organization. And well, the difference with the post-colonoscopy colorectal cancer and interval cancer is that in the post-colonoscopy cancer, you also include the cancers that are detected at the next colonoscopy. And those cancers are divided, as you can see here. You can have an initial colonoscopy, then a screening or surveillance that is planned, and in the middle of that plan, there is a cancer that appears, which we'll call interval cancer. Then it can happen that you have the screening or surveillance colonoscopy as it was scheduled, and you will have another cancer here, which it's considered a non-interval type 1A cancer, or that the cancer appears after having the next surveillance colonoscopy, which will be a non-interval type B cancer. So someone that is under surveillance but has a cancer after the surveillance colonoscopy. And the other ones that are called non-interval type C colorectal cancers are the ones that occur when you have a colonoscopy that is normal and you don't recommend to have any surveillance or screening after it. So the causes for post-colonoscopy cancer have been analyzed in the last times. That has come mostly in the very last 2 years, because the different countries are having these numbers now. And of course, most of these post-colonoscopy cancers will be due to missed cancers or missed lesions. Missed cancers, that's a few ones that will appear in the beginning. Then it can happen of missed polyps or unresected or incompletely resected polyps. And these concepts is what were analyzed in the different papers that I will comment now. But basically, I choose this one, which is a paper from Netherlands. It has been presented by the group of Messmann in the Erasmus, but it comprises all the Dutch colorectal cancer screening. And it's interesting because it's after a FIT positive colonoscopy, and they have included, as you can see, 116,000 colonoscopies, from which almost 10,000 screen-detected cancers, and then 432 post-colonoscopy colorectal cancers were diagnosed. What they did in that study is that they did that division that I was explaining you first, like to see if they could know which ones were interval cancers, which ones were non-interval type A, and which ones were non-interval type B cancers. And they also tried to analyze which could be the reason why this cancer appeared. So they did it like that. They looked if the cancer appeared 4 years after the colonoscopy, they considered it a new cancer. But if the cancer appeared before that, they looked at if there was an advanced adenoma in the same segment. In the case there was an advanced adenoma in the same segment, they would consider it a detected lesion that was not resected or incompletely resected. And if then they looked if there was no advanced lesion, they looked if the second intubation and the bowel prep were sufficient. And in case it wasn't, they will consider it a missed lesion. Sorry. So this is the results. The first result is that the rate of post-colonoscopy cancer after 3 years was only 2.7%. So that's good news. And when they divided, they saw that half of them were interval cancer, 20% were non-interval type 1, type A, and 30% were non-interval type B. And they looked at the colorectal cancer stage of those cancers. And that's very interesting because, as you can see, when we look at the group of interval cancers, the one that appeared after a colonoscopy, before any surveillance or other colonoscopy, 50%, more than 50% of them were advanced stages, stage 3 and 4. Whereas when you look at the other two non-interval colorectal, post-colonoscopy colorectal cancers, you can see that most of them were stage 1 or 2. Especially, I want to highlight that in this group that were the ones that were found in the second colonoscopy or surveillance colonoscopy or screening colonoscopy, most of them were stage 1 colorectal cancers. When they looked at the causes, the etiology that could provoke these post-colonoscopy cancers, they saw that with a group of interval cancer, most of them were due or attributed to missed lesions after adequate examination. And for the type A, it would be incomplete resection or also missed lesions after adequate examination. Whereas for the type B, these are quite different figures. And as you can see here, most of them, 45%, will be due to detected lesions that were not resected or lesions that were incompletely resected, as you can see here. And also missed lesions after inadequate examination, examinations that didn't reach the cecum or didn't have a proper bowel prep. So if we look at the summary of what I show you and the conclusions of the authors, the first thing is that, as you can see, most of the post-colonoscopy cancers in the Dutch screening program were interval cancers, and they were late cancers, stage 3 and 4, due to missed lesions after adequate examination. They also show that 20% of them were, in general, were diagnosed after incomplete colonoscopies. This is part of their conclusions, but they didn't really found the data on the presentation. So the first thing that struck my attention, and maybe it would be nice to discuss it, is that in comparison, for example, with the UK, that already also showed their data on post-colonoscopy colorectal cancer, but it's not only in the FIT program, it's in the whole, it's much lower than what was previously published. So maybe that is due to the fact that in Netherlands this is very well organized and there is a quality program, but that is interesting. Then also I wanted to highlight that these non-interval post-colonoscopy cancer, that are the ones that are found in a colonoscopy that was scheduled, maybe conceptually are very different, because it's just lesions that are, most of them, stage 1 lesions, PT1 lesions that are probably treated endoscopically. So probably this is not such a bad news, and maybe even can be considered a success of our screening and surveillance programs. And the other question is about here, this conclusion, this that really strike my attention, is that in those cancers that occur after a surveillance colonoscopy, most of them were due to lesions that were not removed, which is curious. And I would be also very curious about what was the adherence to surveillance guidelines, how many of those cases really underwent the surveillance colonoscopy. So then, as you all know, this post-colonoscopy colorectal cancer is what we want to avoid. And now for a lot of time, we know that missed lesions are one of the important things that we have to avoid. And we know that the ADR is a good surrogate marker to know this post-colonoscopy cancer. And we know that as higher an endoscopy has its ADR, as less probable it's the chance that the patient that has been has had a colonoscopy with that doctor will have a post-colonoscopy cancer. And this last year, there were two very nice studies from the same authors that presented now this data at ESGE Days, one from this group that I already presented you, and another one from the one that I will present the next abstract, that have again analyzed the relation with the ADR and the cumulative colorectal cancer incidence. And here, about this ADR, how to increase this ADR, for many years we have been presenting a lot of abstracts in the Congress, and I have chosen this one, which is quite simple, because I think that is easy to use when you go home. And it's a study done in Spain by several hospitals that are not especially big and academic hospitals, but hospitals where they do FIT-based screening colonoscopies, and where they did a randomized trial parallel, where they randomized patients to undergo their colonoscopy with the endocuff and without the endocuff. And what they saw is that despite in the standard colonoscopy arm, the area was quite good, 51%, so they are, like, let's say, good detectors. The fact of adding the endocuff made to increase the ADR 8.8%. They also show, curiously, that the time to reach the cecum was also better when using the endocuff device. So there were no differences for the other things that they looked at. So, well, now there's open questions. Which one should we use for whom and which combination? With all these available tools that we have, and especially with all the CADI that have already also demonstrated that provides better adenoma detection rate. But if the combination of endocuff that will help you to better visualize all the aspects of the mucosa and the artificial intelligence will really be the answer. So another question, we are talking about adenomas, but we also know that sessile-serrated lesions are very important and are responsible for 20% of the colorectal cancers. So the question is, what happens with the detection of sessile-serrated lesions? And that was the question done by this group from Italy with Giulio Antonelli, that they wanted to look which was the influence of single endoscopist sessile-serrated polyp detection rate on post-colonoscopy cancer incidence and their relation with the ADR. So they analyzed their program in the Veneto region that includes FIP positive patients, and from this a very large number of colonoscopies, 110,000 colonoscopies, they looked at all the post-colonoscopy cancers that they have, that you can see here, that are a number very similar to the one in Netherlands. They had 133 endoscopists, their mean ADR was 48%, and the first result from this study is that the mean sessile-serrated lesion detection rate was only 1.6%, with this interquartile range that you see that is quite wide, and sometimes going up to only 0.75%. So they looked which was the relation with the different rates, the people percentages of their detection. And here you can see that these are the ones that detect less sessile-serrated lesions, and here the ones that detect more. And you can see here the rates, the number of post-colonoscopy cancers, and you can see here the Hazio ratio, and you can see that the probability of finding a cancer is higher for the low detectors than for the high detectors. In fact, if you look, as we are used now to see that, for each 1% increase of detection in sessile-serrated lesions, that will imply a 9% decrease in the number of cancers, and it's the same for ADR. And here, what they looked, which is interesting, is that they divided the endoscopists in those ones that were high detectors for adenomas, and the ones that were low detectors for adenomas, and also for the ones that were high detectors for sessile-serrated lesions, and the ones that were low detectors for sessile-serrated lesions. And they grouped them, and you can see here in red, it's the ones that were high detectors for adenoma and high detectors for sessile-serrated lesions, that those ones were the ones that had less level of post-colonoscopy cancers, but very similar to the ones that were high detectors for adenoma detection and low for sessile-serrated lesions. So it seems that adenoma detection rate was more important than sessile-serrated detection rate. But when you looked at the ones that were low detectors for adenomas, here you can see a difference, that the ones that were high for sessile-serrated lesions had less post-colonoscopy colorectal cancers than the ones that were low for everything. So they looked also at the correlation within the adenoma detection rate and the sesal-separated detection rate. And as you can see, there was a moderate correlation with some people that would be very good at everything. But as you can see, some people could be good at sesal-separated lesion detection and not adenoma, and the other way around. Some people were good at detection of adenomas, but not so good at sesal-separated lesion detection. So their conclusions was that adenoma detection rate seems hierarchically superior to sesal-separated lesion detection rate, and that ADR is moderately correlated to SSPDR. This is similar to the Dutch experiment that was recently published as well. The difference in this Italian study is that there was a very low prevalence of sesal-separated lesion, and that was something acknowledged by the author that is also here for the discussion, so you can discuss with him. And the conclusion is that probably we should also focus on our sesal-separated lesion detection, training, and auditing. So as I was explaining in the first abstract, one of the causes of non-interval cancer, of post-colonoscopy cancer, is the fact that some lesions are not resected or incompletely resected. And that's why I have included this abstract, which is a very simple abstract that will talk about piecemeal EMR, that you know that is the treatment of choice for large non-pedunculated colorectal polyps. And in this very nice study from Netherlands, what they did is they based their study on the fact that we know that recurrence rates after piecemeal EMR can go up to 30%. However, we have now a lot of data from mostly expert centers or academic centers where this can be as low as 4%. So the question is, should we need a national standardized training to really have these 4% recurrence rates? And does everyone know how to do EMR? So what they did was to look at 30 Dutch centers, and they did a cluster randomization. So to some of the centers, they did a training with an e-learning and 2 days EMR course. And to the other ones, they did just the usual care. We have to say that all these centers were centers that were certified to do screening colonoscopy, and where there were people that were theoretically experts or quite knowledge on EMR. So that training was only a training for people that already were doing EMR. And they did that randomization, and they collected all their EMRs and looked at the recurrence. So they finally had 1,412 patients included, 699 in the intervention group, and controlled 700 patients with a mean age of 60 years. Lesions were mostly located proximal and sessile. The size were 30 millimeters, going from 25 to 40. Patients were, half of them were SMA, were complicated lesions, as you can see here, 50%. And what you can see is in the histology, most of them were adenomas. Here are some technicalities on how the procedures were done in the intervention and the control group. And you can see that in the intervention group, there was more often use of colloid lifting fluid, because this was something that was explained to the people that were coming. Also, more tissue snaring from the residual snaring, and also more adjunct treatment performed and margin thermal ablation performed. But that was also 80% happening in the control group. So these are the main outcomes, which I think are very interesting. You can see that in the control group, the recurrence rate was 25%. And in the intervention group, it was 13%. So it really, this intervention, quite simple, was very successful at reducing in community-based centers the rate of recurrence after piecemeal EMR. The complication rates and the interprocedural events were quite similar. Also, the size of the recurrence was similar, but what is interesting to see is that there was more multifocal recurrence in the control group, which we think very much could be related with the fact that the people were not removing the pieces one with the other. There were bridges in the middle. When they looked at the sizes of what happened with the sizes, you can see that the differences were not, it did not exist anymore with lesions larger than 40 millimeters, because these lesions are probably more complicated to remove even for people that receive this short training. So this is the conclusions. And a standardized EMR training that is quite simple is very successful. There is no improvement in the more than 40 millimeters lesions. So this is also something that I think would be nice to discuss afterwards. And now I'm going to move to something a little bit different, which is early colorectal cancer. That is that cancer that invades the submucosa. And we know that from 2 to 13 will have lymph node metastases, and less than 20 residual tumor, and 80% will be treated with surgery and probably will receive an overtreatment because we won't find any lymph node metastases after surgery. So we know that surgery has mortality and morbidity and costs, and that's why we are trying to reduce this overtreatment. To have a local treatment that is curative, we need that this local treatment is radical and block ERV0 resection, and also that there is an absence of high-risk features in the histology. Basically, poor tumor differentiation, lymphovascular invasion, and intense tumor budding are the ones that are considered high risk. Deep submucosal invasion was also considered high risk feature, but there is several evidence in the last 2 years that has demonstrated that per se, as a unique item, this can be considered as a risk feature. This is why when we look at the options that we have endoscopically or locally to treat, when we are talking about very small polyps, we could consider EMR, but it's not the ideal one, but we can consider it because we can remove it and block, but this will be limited by the size. The other option for the lesions that are larger are ESD, because this will provide an en bloc one-piece resection, but this will be limited by the vertical margin because we will be in the submucosal plane, and that will mean that if the lesion is deep in the submucosa, you have high probabilities of having a margin that is not clear after after doing a complete en bloc resection. The other options are full thickness resection. There were some abstracts on that I haven't chosen, but it's also a very interesting topic. And that can be useful, especially for small lesions, smaller than 20 millimeters. And for the surgeons, for the rectum, they have the TAMIS. That was a good option because they will remove all the full thickness of the rectal wall and they won't have the problem with the vertical margin. But they have the problem with the fact that they will do a scar that then will hamper the salvage surgery in case that you need to do a secondary surgery. And here is where comes this new technique that was developed first in Japan and then has come to Europe and has been already published firstly by the group from Netherlands, and that consists of doing an intermuscular dissection in the rectum. That means that instead of this dissecting through the submucosa, you will dissect through the two muscular layers of the rectum wall. And the advantages is that you have a deeper, so you won't have the problem with T1s of having the deep vertical margin affected because you will have a deeper plane, and you will accomplish higher rates of ERV0 resection that have been demonstrated to go up to 93%. And it will also preserve the mesorectal plane in case of needing a future surgery. In the right hand of this slide, I have included the video by Tribonias from Greece that presented in the session their experience with the 10 cases, their first 10 cases, and the author is here to answer to your questions as well. So for technicalities, he can probably help you to answer any question. So here you can see how they are entering into intermuscular space and dissect through this space the same way that you would do it in the submucosa. I continue for time reasons. So here, what I found very interesting is that the group from Netherlands were presenting the outcomes that are related with patients, not the ones technical that were already published, the ones that I think that are very interesting when you need to take decisions, that are the adverse events, post-procedural recovery, and functional outcomes. And they presented the results from their series of 140 patients included in the last 3-4 years. Patients were 65 years old, lesions were around 30 millimeters. Most of them were distal, located in the rectum. As you can see, the technical success was very high, 96%. Sometimes they had a small defect, never peritoneal entry. Most of the small defects, the defects were small, and most of them were treated with clips without any problems. And what is important is that the patients were discharged 1 day after the procedure. The rate of adverse events was quite high, 36%, and mostly it was pain. Pain was the most important adverse event. Most of them only needed paracetamol or NSAID, but a few patients had a significant pain. That means that they had that pain for more than 7 years and needed opiates. It was 6 patients, and mostly it was lesions that were located very near the dentate line. The other adverse event was the need of therapeutic antibiotics due to fever in 7% of the cases. No one had an infection or a rectal abscess, and a mild delayed bleeding in 2% of the cases. They did a questionnaire to the patients, and the rate of response was very high, 80%. And the question was when did they return to the daily activities? And what is interesting is that most of them were able to return to their daily activities in the first 3 to 7 days, so mostly before 1 week. And I think that this is especially important. They looked at the functional outcomes, looking at the low anterior resection syndrome with a questionnaire with a median follow-up of 20 months, which is a very interesting outcome. And what they saw is for the patients that underwent only the intermuscular dissection, only 5.9% of the patients will have a major LARS, which, to put it into context, this is quite rare because for TEM and TAMIs, the numbers go from 6 to 29%. So it's probably better than TAMIs and TEM. The only thing is that in those cases that underwent second therapies, like chemoradiotherapy or a surgery, these numbers were higher, of course. So these are all my presentations, and I am here to help you with the questions and with the different presenters.
Thank you, Maria, for this great selection. It was a difficult task, I think, but it showed me again that the ESGE Days is meanwhile so popular that the people send their best abstracts, and we have a chance to demonstrate several times those great papers. So for this session, I think there are a couple of authors here. It's Fernando Zabado, it's George Triponias, Giulio Antonelli, Lonnie Moylan, Sanders Albers. So maybe Maria, you want to ask directly, Sam, and we have also some questions in the chat.
Yeah, I think I would suggest maybe to answer to the questions in the chat. Don't you think so?
Yeah, there's some interesting questions already in the chat. So there's one about the difference of the recurrence rates in interval and non-interval between the difference between right and left side colon cancer. About the first study, I think.
Mm-hmm.
Can you tell us? Yeah, can you tell us something about right and left-sided post-colonoscopy in the various group, interval and non-interval? I don't think the author is not here, and I couldn't see that in the presentation. So probably what has been shown in another presentation in that same session is that there are more common interval cancers in the left colon, because generally there is more colorectal cancer in the left colon. So probably it's more related with the, let's say, the epidemiology of the cancer, that it's more common to have a cancer in the left colon. And so even if we have always been saying that in the right colon, it's more common to have colorectal cancer, that is not totally true. In absolute numbers, there is always more colorectal cancer in the left colon. It's just that if you look at spontaneous or sporadic, let's say, colorectal cancer and post-colonoscopy colorectal cancer, then the proportion of right-sided lesion is more common, let's say.
Mm-hmm.
There is a question about the tools that can help us increase our adenoma detection rates, and in the light of the abstract that you showed and the recent publications, the network meta-analysis, for example, is there any tools or types of scopes that are recommended as a routine to minimize missed rates of post-colonoscopy colorectal cancer, like the endocuff or the special scopes with a balloon to straighten out the folds? Any recommendations on that?
Yeah, I think that maybe we can use that Fernando Sabato, the presenter from the abstract on endocuff, is here, and we can ask him his experience with the study and what were their feelings about the use of endocuff, and if they think, do you think that you would recommend to use endocuff in all the screening procedures after your trial?
Yes, hi, thanks for selecting my abstract. And it's a good question, because in the question, general question asked about in all patients, and they should know which the cause of the colonoscopy. I think for all causes is not necessary, but in screening, our results say that we should use in all screening program. But we have to select. I think really it's not all person, because if you have a very higher adenoma detection rate, it's very difficult that you can increase with endocuff or with artificial intelligence or another devices. And sure. For me, most important is not if you have to use or not to use. Most important is you have to know which is your adenoma detection rate. And if you know which is the adenoma detection rate that you have, you could or you should have if to use or not to use the devices. For all patients, I say that no, but for all patients in screening, I think it depends about which is the adenoma detection rate that you start.
And Fernando, can I ask you something? Why do you think that you had this more quicker time to get to the SICOM when you were using the endocuff?
When you use the endocuff, first sensation or first feelings is more difficult to pass the sigma, but really this feeling when you pass the sigma and you start to push and pull the endoscope, the arms of the endocuff help to you to rectify the colon, and it's easy the rest of the colonoscopy to reach the cecum and fix the angle, the hepatic and splenic, and you will arrive faster. It's a surprise for us in our result, but there's another study that say the same, that when you use endocuff, you think it or always think that it's a slow colonoscopy, but really it's faster because could do a better rectification in sigma.
There is a comment to Julio's study about serrated lesions, which is, I think, important, that time does matter. My question is, Julio, was it a surprise, this result for you? I would expect if you have a higher sessile detection adenoma rate, you are really good, and then you must be better than the Areia. But this was vice versa, no?
Yes, no, thank you for the question, Helmut. I agree. It was a surprise, although it was quite old data. So it was from 2012 to 2017. Indeed, we are planning to expand our analysis and to see if in the recent time, we had a chat also with Peter Visse and David Toledo, which are the other authors of the Dutch paper. And we were trying to figure out why we have these differences, but actually, when we go and look at their data is more recent. So probably it reflects the increasing awareness of sessile serrated polyps. So I expect that when we will expand our analysis to 2021, for example, we will see an increase in our SSPDR, although I think we need as a screening program to increase awareness among community endoscopy as they did with the Dutch experience, because the Dutch guys had a great long-standing experience in increasing the awareness of sessile serrated polyps with educational tools and various interventions. So of course, I agree also with the colleague, if you have to know what you're looking for, and then you will find it.
Mm-hmm, mm-hmm. Yeah, yeah.
There is another question about the EID. So we have George and Sander here that both the abstracts both focused on that. One is about the recurrence of T1B rectum cancer.
Yeah, I can.
You take that?
Yes, sure, because I think we have a bigger group. No, because I think of the 140 people we treated with EID, about 75 had a deep submucosal invasive cancer, and about 80%, 75% also chose for a organ-preserving treatment strategy. And during those 18 months of follow-up, we only had one recurrence in the, well, we called it the low-risk deep submucosal invasive group. We also had a recurrence, 2 recurrences in the group that had high risk factors next to the deep submucosal invasive cancers. So actually the recurrence rate is about 2-3% in this group. And it's also the same we had in our EFTR group. We also have a big group of T1 that we treated with EFTRs. And we have, I think, about 30 or 40 months of follow-up, and also like 2-3% of recurrence in the group with the low risk deep submucosal invasive cancers.
So it's pretty good, huh?
Yes, yes.
I totally agree with Dr. Albers. We have a minor experience than the Netherlands. We have completed 30 cases, and we have only one recurrence in a patient that had a total neoadjuvant therapy and then an intermuscular dissection. Mm-hmm. So I think that this 2-3% of recurrences is a great percentage that Dr. Albers suggest us.
And George, maybe for your cohort, how about the learning curve? Was there something that you could deduct from that? I mean, from after how many procedures that you were getting faster or more accurate? Mm-hmm. Or
regarding the speed of intermuscular dissection, is quite the same with ESD speed when an expert performing the procedure. And I think that the intermuscular space is not so difficult space. It's narrow space, but the endoscope is well stabilized in that space, the intermuscular space, and the dissection with a dedicated knife for myectomy is quite simple and fast. I don't know which is the experience from the Netherlands, but we think that an expert ESD performer can go to the intermuscular space quite easily.
Mm-hmm. A question to both: what is the best selection for those patients? Where do you think we should go for EID and not for ESD?
I wait for Dr. Albers.
Yeah, I can comment as well.
The experience.
When are you performing EID?
So in our group, we also have a prospective registry at this moment, a multi-center study with 6 centers in the Netherlands, and our inclusion criteria are so CT1-2 on the MRI, of course, no nodal positive nodes, and also optical signs of deep submucosal invasion.
Mm-hmm. Mm-hmm. Do you close the defect after the resection, or do you leave it?
I think at the beginning we were a bit more careful, so we closed most of the defects. But I think also most of the especially the smaller defects are like the orifices where the vessels are penetrating the muscularis propria. So we actually leave those open as well. And we also did an analysis in our group where we looked into whether or not we closed a defect and did we have more adverse events if we closed it or not. And there was actually no difference between the two groups.
And any knife which you prefer? This was in the video, it was a hook knife, which is also my favorite, but experience with other knives?
I think in our center we used the 1.5 millimeter dual blade knife. So I think it's the standard ESD knife.
Yeah, okay, thank you.
We have also left all the defects open, these 30 cases, and we hadn't any serious adverse event. And we use also the dual knife of the stomach, the 2.0 dual knife for the aid resection is very useful, together with the hook knife. And I think that the dissection is faster with the dual knife, stomach dual knife.
So I have a question for Lon and Maria about the piecemeal EMR, which is becoming, as you said, a standard. And you very nicely show that you have a standardized way of teaching it. It's also better. But do you think that all colonoscopists should know this technique, or it's still something that you refer to?
Well, if I can answer, I think it depends on the size of the lesion, because we've seen this in this study that those are experienced endoscopists for EMR, and you see that training gives a positive effect at recurrence rate, but from 4 centimeter or larger, this positive effect seems to disappear. And also a study of our group in a bowel cancer screening cohort showed that in the community endoscopists who perform EMR in the bowel cancer screening population from 3 centimeter and larger lesions, the quality of polypectomy goes down if you compare it with the level of experts. So I think piecemeal EMR on larger lesions could be for everyone, but from a certain set point of size, I think 3 or 4 centimeters, referral is the way to go, I think.
That makes sense, yeah. Maria?
Yeah, probably
as expert.
No, but that was one of the conclusions of the study, because that was interesting, because that was done, I mean, in a country as Netherlands, which is probably quite homogeneous and well distributed things in comparison with other countries. People that were already doing the MRs at their centers. I mean, it was people that were considered the experts at their centers. And despite a group had this specific training that was simple, still we couldn't decrease the rate of recurrence. So probably that means that for these very large lesions, still we need someone that has more experience, as always. No, you need to do more numbers.
Yeah, it's also a question of exposure, because we've seen in our cohort that if you look at all the centers that participated from the Netherlands, the mean exposure of the very large lesions to the individual endoscopist was between 0 and 7 cases per year. So it's very difficult to achieve a good learning curve for the very large lesions. So therefore, centralization is one of the suggestions we made for these lesions.
Well, thank you very much.
Yeah.
So I think we can wrap up. We are still 150 participants, which is a pretty good record for 8:30, huh?
Yeah. I have to apologize, Marianna. We thought it is, well, apologize. It was somewhere planned between 60 to 90 minutes. It took 90 minutes, but it was brilliant to have all the authors.
Yes, I think it was really great. And we thank you all for being there at such short notice. It's been really a pleasure to have you and have your comments live, and to have so many people from the audience following. And of course, thank you very much to both Miguel and Maria, who did such a great work in giving us an overview of your favorites abstracts, which is also important, that you very nicely presented the background as well. So Even myself, who is not very colon or upper GI, I really got the best of it. So thank you very much to both of you. So maybe we can wrap up then.
Yeah, excellent job. Then, yeah, Maria, please. Marianna, sorry.
So join for the benefits day to make a difference. And it's renewal time for the ESG. And of course, you can still go and check out all the abstracts and the sessions, because we have ESG days on demand until June 30. And that's only 2 days after the live demo webinar, I remind you, which is, when did we say it was, Helmut?
28.
28, yes.
From the both live centers, Hamburg and London will show their highlights from the live.
And of course, 2024 in Berlin, start booking.
Yeah, you should start booking, definitely. We expect, yes.
Jubilee, it's the Jubilee.
It's the Jubilee, and we expect 5,000. Maybe it's the first Congress where we have not enough space and have a waiting list.
Big party.
People should register very soon.
Save your seats. And of course, for all you young people out there, the fellowship grants, deadline approaching. So you can go to the site for full details to have a unique opportunity to have an experience of an international abroad. So that's also a great opportunity. And of course, thank the ESG Governing Board and our great webinar team, David and Gabby, who always do this in perfection.
Okay.
And of course, thank my president.
now being past president. And thank you, Marianna, for doing this wonderful job as scientific committee chair. I think it was really great to work with you. But now we are in the middle of the planning for next year. And as said, Berlin is waiting, join us. But for the next weeks.
Our scientific committee is already at work, huh, Maria?
Yeah.
They've already given all the programs, so we're already working on it.
Okay, so thank you, everybody. I think now we should really close the session and wish you all a nice evening and hope to see you by the next webinar for ESGE Day highlight. Thank you. Bye-bye.
Good night, everybody. Bye.